So why MD codes? Because before MD codes were introduced, the problem that injectors were facing was, first of all, they didn't know how much filler is required to address a certain aesthetic concern. Like there has to be a minimum quantity and a maximum quantity for particular aesthetic concern, where it has to be placed exactly to give that result. Now we all know that the principles of dermal fillers, they are derived from the principles of cosmetic surgery itself. They're deciphered, the principles are deciphered from the principles of cosmetic surgery, and they are implemented in a way that we are trying to mimic the effect of surgical treatments with a non-surgical approach. That is basically a concept of dermal fillers. MD codes se pehle, the problem was that we did not know how much filler is required. For example, for nasolabial fold, if I was injecting nasolabial fold, I was in dark. I used to sell 1 ml or 2 ml for all types of faces, slim faces, heavy faces. We were telling just 1 ml or 2 ml, and we were directly injecting the nasolabial fold. So sometimes the results were good, sometimes they were not good. So why they were not good? Because the requirement, or because when you're calculating the financials, you see that if the person is able to afford 1 ml, we used to sell 1 ml, and in 1 ml we used to do 2 nasolabial fold, which is absolutely nothing. So there has to be a minimum dose, there has to be the right site, there has to be the right delivery of the product in the right amount at the right place. So this is what the MD codes has done for the injectors. And this was introduced by Dr. Mauricio de Maio. He is a well-renowned plastic surgeon from Brazil. And he has given these codes, because of which the dermal fillers, the results with dermal fillers have become more satisfactory. The doctors are more confident while they are injecting, and they can promise the results what they, they can deliver.
Yeah.
So what are medical codes? The face can be split into distinct anatomical units. So there are 14 to regional units and anatomical units of the face. And these are a series of predefined injection sites or subunits within each anatomical unit. And they will demonstrate how to rebuild that particular unit in an architectural mode. Now, what do you mean by architectural mode? Now see, the face has basically, broadly when we classify, 5 layers: bone, deep fat, mass, superficial fat, and skin. This is broad classification, right? So changes in all the layers are being reflected on the surface, right? So what changes are being reflected on what extent, to what extent on the surface, is what we mean by the architectural mode. So there are some changes like this piriform fossa. It is more because of the recession of the maxillary bone.
Yeah.
Right? And there are some changes which are happening. So all the tissues are aging at a different pace. And to understand that, we have to understand the etiology and physiology of aging, which we will be further discussing in further sessions. So when we talk about the facial regions and more, first we have forehead, then the periorbital is the lateral periorbital region. Mostly we do it with dermal filler. Medial periorbital and medial forehead, we don't usually advise for dermal fillers. Then we have the cheeks, lips, chin, the marinate lines, the nasolabial folds, the jawline, the tear trough, temples, glabular region, and the eyebrows. So these are the various places where we put the dermal fillers. These are the medical codes are specifically for these regions only. Now, the letters are there, which represent the anatomical units. The numbers are there, which is the structural subunit. The location is right or left, we write with small r. The position is upper or lower face. This slide deck I'll share with you so you can refer, or maybe you have it, then it is fine. The shapes is like technical delivery of the product, like with cannula or needle. How do we place the product? The colors, like red zones, or the zones where arteries are there. There it is indicated by a red zone. Gender differences, there are some points which are specific for men, and there are some points specific for women. For example, when we are doing chin. So chin, there are different points for men and different points for women. Same for the jawline also. The certain points are different for men and women. Injection devices, we have broadly two devices. One is the cannula and one is the needle.
Yeah.
The delivery and the targeted structures. Now there are four areas where we can, four layers, different layers where we can place our dermal filler. First is the dermis, then if it is lips, then it is the mucosa, then subcutaneous and supraperiosteal. So these are the four different layers in which the filler can be placed. And the techniques,
Yeah.
micro aliquot, small bolus, linear threading. It could be anterograde or retrograde linear, and fanning. So these are the four injection delivery techniques and the different structures where we are delivering the products. Alert areas and do not inject areas are specifically marked. So complications we'll go do in the end. I will start with the mid phase first. So MD codes for the mid phase that we have. So before injecting, we have to understand the anatomy and physiology of aging. So first thing, important thing that we have to know is that mid phase is a region where the maximum changes of aging are occurring because the underlying bone is more prone to recession in that area. The maxillary recession, if we study, it is maximum as compared to other bones in the face.
Yeah.
Right. So which is why the earliest signs of aging and the number of signs of aging are maximum in the mid phase. This is the first thing why we start with mid phase. The second is that mid phase acts as anchoring for the lower phase also. So when we inject the mid phase, we are to an extent treating the lower phase concerns also. So that is the second reason why we start with the mid phase always. And third reason why we start with the mid phase is because when we are looking at ourselves in the mirror, it is the periorbital area and the mid phase area which we are mostly focusing at. We are not, subconsciously, it is the central zone of the face which we are looking at. We are not looking at the peripheral zones.
Yeah.
So this is why the aesthetic concerns are mostly and initially and maximally noticed in the mid phase. So these are the three basic reasons why mid phase is the preferred choice, both anatomically, physiologically, and from all other concerns, psychologically. From all aspects, mid phase is the most pressing, presents with most pressing concerns. Right?
Yeah. Yeah.
So let me know if there is any doubt or anything you want to ask.
No. Yeah, I'm clear. I'm clear about it. It's all clear.
Right. So there are the bony structure we have, that is the lacrimal bone. We have the zygomatic bone, and all these zygomatic process of maxilla, temporal process of zygomatic, and all those bones are there. The zygoma is responsible for the convexity and projection, producing attractive high cheekbones. Right. So now, the main concerns which are there is the cheekbone. Individuals, female, women, they are concerned about the cheekbones, they are concerned about the under eyes, and they are concerned about the nasolabial fold. These are the three major concerns. So the convexity and projection of the high cheekbones is by the zygoma. The periorbital area, the under eye dark circles, not dark circles, under eye hollowness is contributed by, first of all, the orbital rim that is responsible, and the SOOF, that is the fat pad overlying the orbital rim. So these two are the concerns. Now, when you analyze an under eye hollowness individual, you have to see what is it, the bony contribution more, or is it the fat pad contribution more?
Yeah.
Although the treatment is the same.
Yeah.
Right. And then in the piriform fossa, again, there's a deepening of this fossa, which is because of the maxillary recession of the bone. Right. Now, sometimes what happens, there is bony recession, but the individual is like overweight. So they have the fat, facial fat is, compensating the bony recession. So thereby, that is why they might not be showing the same signs of aging as a person with a slim face,
Yeah.
right?
Yeah.
So this slide I'm not covering because this is relevant for Botox, not fillers. Now this is a SMAS, which is a fibromuscular layer, and I think you must be better aware about these, the SMAS and the
Yeah.
face in the face and neck, and it invests and interlinks the mimetic muscles of the facial expression. It acts as a unit, like it is like a hammock in which muscles are sandwiched, all the tissues are sandwiched, and sometimes they are anchored to the bone, from bone to skin, and sometimes there might be just superficial.
Yeah.
So doctor, if this meeting ends, then you let me know what to do. You want to repeat it or you want to realign to another day? You let me know.
Yeah. Yeah. Is it for 40 minutes only?
Yeah, 40 minutes.
Yeah. Yeah.
So the retaining ligaments anchor and stabilize the skin and the facial fascia. So all these are the retaining ligaments which we have to be thorough about. The tear trough ligament, the upper mesenteric cutaneous ligament, superior temporal orbicularis retaining, zygomatic cutaneous. So when we are considering about the mid phase, the most important is the zygomatic or cutaneous ligament and the orbicularis retaining ligament and the tear trough ligament, which is extending medially. Right?
Yeah.
The others are relevant for the lower phase. So we are doing mid phase. Then there's the subcutaneous facial fat exists in distinct anatomical compartments. So there is deep fat, there is superficial fat. The deep fat is mostly responsible for giving the structure, and the facial fat, superficial fat is basically contributing to the contouring. And the way in these two fat layers are aging is also different, right? So, for example, when we talk of mid phase, we have the SOOF and we have the roof, and then we have the cheek compartments, the middle cheek compartment, the lateral temporal cheek compartment, the medial cheek compartments. So when we are talking of these compartments, we are when we are injecting the mid phase, mostly we are replacing the superficial fat pads and not the deep fat pads. On 2-3 concerns which are not dealt with the injecting of superficial fat pads, we do it with a deep. For example, when we are doing the periorbital area or under eye hollowness, it is always advisable to inject deep and not superficial.
Yeah.
Right?
Yeah.
But most other concerns like anterior cheek flatness, that has to be dealt superficially only. Lateral cheek lifting, that has to be deep, because there we are aligning, not filling. So as we come across each indication, I'll be mentioning the fat pad that we are dealing with over there, or the ligament that we are dealing with over there, and how to deal with it. So malar fat refers to the 3 fat compartments: the middle cheek, medial cheek, middle cheek, and lateral temporal cheek.
Yeah. Okay.
This is the facial artery anatomy. I think, do you want me to go through this slide?
No. I'm aware about it.
Yeah. So effects of aging on the mid phase. This is something which is very important. If we get better insights, the maximum insights we gain into the effects of aging on the mid phase, the better we can plan them. There is intrinsic aging, which is caused by loss of organization of the subcutaneous. So three aspects of aging will be there. One is the changes in the bone level, changes at the fat level, and changes at the skin level. Right? So what we are dealing with the dermal fillers is the intrinsic aging, effects of intrinsic aging. And when we are dealing with skin boosters, that is the effects of extrinsic aging that we are dealing with. So extrinsic aging, all the factors are there, the photo aging, the UVA, UVB. I'm not going into the details. If you want me, I can go into the details, but I'm sure that this is, already, the extrinsic aging.
Yeah.
Yeah.
Yeah, I can understand that.
Yeah. So intrinsic aging produces dry and atrophic skin with fine lines and increased laxity. And the photo aging is, of course, by the UV rays. Now, mid phase loses its uniform round fullness and forms a more square or Y shape. That is, we have the triangle of youth initially, and that gradually it becomes a square face. Why? Because because of the gravity, everything is falling forwards and downwards. Right.
Yeah.
So that which is why what people perceive, how do people perceive this? Now, the way they perceive is that their photos, they feel that they look overweight in photos because, when we take our photos as it is, we are amplified to an extent, 70-80%. It shows more, 20% more of what we are.
Yeah.
Moreover, secondly, the effects of aging, everything is falling forward. So the middle of the face becomes heavier.
Yeah.
So they perceive it like they're looking overweight in pictures.
Yeah.
So mid cheek, and this starts developing like mid cheek groove, which develops infralaterally. The palpebromalar groove, this is over here. The nasojugal groove medially. Right. And so this is the cause. These grooves are caused because of the descent of the fat pads.
Yeah.
Right. So because of anterior descent, the mid face, the middle of the face becomes heavier. The grooves become more prominent.
Yeah.
And the nasolabial fold, this also becomes more prominent.
Yeah.
So these are perceived as aging. So this is a triangle of youth that we see. Mid face ptosis and lower face jowls inverts the triangle of youth, moving an oval face to a square face. So atrophy of the maxillary bone below the orbit is major contributor to the laxity and descent of the medial soft tissues. So it is basically the underlying maxillary bone which is undergoing changes, because of which all these are manifested in different ways and different aesthetic concerns on the face superficially on the surface.
Yeah.
Now, volume loss in mid-face has multiple consequences. So what are the results? So facial aging is masked by, first of all, atrophy of bony skeleton and tissues, descent of the ptotic cheek fat, and depletion of malar fullness. So these are the ways in which we are seeing the changes. And together, these will cause the orbital aperture is also widening, right?
Yeah.
They reduce anterior projection. So which is why there is a flattening of the anterior malar area. Reduced overall projection and concavity of the cheek. So cheek becomes flat. Then reduced support for the overlying soft tissue structures. So descent of malar fat pad can lead to two things. One is the infraorbital hollowing, and second, deepening of the nasolabial folds and nasojugal folds.
Yeah.
So when we have to treat the malar fat, if we have to treat the infraorbital hollowing, we first have to treat the cheek.
Okay.
Early, before treating nasolabial fold and nasojugal groove, we have to treat the cheek.
Yeah.
Because what is the cause of it? Because malar fat pad descent is a cause. So we have to realign the malar fat pad, whatever structure realigns it, that is a zygomatico-cutaneous ligament. So that is why you should not and should never treat the nasolabial fold directly without treating the cheek. And you should never treat the infraorbital hollowness without treating the cheek. So anybody, any patient, any concern, do the cheek first.
Yeah. So this zygomatic cutaneous ligament is more linked with the under eye hollowness or more with the nasolabial?
Both. See, it is one. See, if I have to explain it, all these structures, they are tied in the fascia and they are connecting to the zygomaticofacial ligament, which is like aligned, which is like hooked over here.
Yeah.
Right. Now, what anatomists say is that the ligament does not undergo any changes.
Yeah.
But the bone which it is anchored is getting resolved. So because of which the ligament is loosening. The anchor point of anchor is getting loosened, and everything is coming down. So the malar fat pad is coming forward and downward.
Yeah.
So because of this, we have under eye hollowing, we have deepening of the nasolabial fold, we have the deepening of the nasojugal groove, we have the formation of jowls.
Yes. Okay.
Right?
Yeah.
So the first step is to realign the zygomatico-cutaneous ligament. The moment you realign this, there will be improvement in under eye hollowness, there will be improvement in nasolabial, and there will be improvement in nasojugal.
Can you just mark? Yeah,
Yeah.
where is the zygomatic cutaneous ligament in this diagram? Can you just mark with the arrow or something? Where exactly, like,
In the
um,
slide that I'm showing right now,
yeah, yeah, yeah.
the ligament is not shown over here. It is like,
Okay,
it is on the zygomat. This area this is the place where the zygomatico-cutaneous ligament is anchored.
okay. This,
It's a true
yeah,
ligament. Yeah. It's a true ligament
yeah,
from
like,
bone to skin,
yeah. This is zygomatic cutaneous ligament, roughly.
roughly. This is the area where it is there, right?
Yeah, got it.
And
Yeah.
this will be also the area where the orbicularis retaining ligament is there. So zygomatico